Welcome to the Skeptic's Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is November 27th, 2025, and I'm your skeptical host, Ken Milne. The title of today's podcast is Andromeda. Cap refill time for personalized sepsis treatment. And our guest skeptic is a good friend. Oh, we go back to the Beam days. Yes, it's Dr. Justin Morgenstern, who is an emergency physician and the creator of a wonderful FOAMed project. You should all check it out. It's called First 10 EM. Welcome back to the SGEM, my friend. What have you been up to?
Oh man, just dreaming of the good old days when I used to be on here every month with you. We got to chat all the time. It was good. Just been missing you, my friend.
Well, family first. Family comes first, and then our clinical work, and then our FOAMed stuff. Right? It's on the side. It's free, open access. You and I aren't getting paid by Big Foam to do this. We do it because we love it, but we love our families more. You approached me about this study. Actually, somebody sent me a copy of this study. How this happened is somebody sent me a text or an email or something, and reached out and said, "Hey, do you hear Weingart mentioned you on his show about this study Andromeda?" And I had not listened to that episode yet. And then boom, right after that, I got something from you saying, "Hey, you want to talk about this study?" And, but hey, I don't want to spill the beans on what the cool part is from a nerdy standpoint. So why don't we just get into it? You give us a case and we'll go through it and hit the nerdy section.
Yeah. Tried and tested SGEM format. Let's do it. So you're looking after a 65-year-old man who appears to be in septic shock. He presented after 5 days of fever and cough and is now severely lethargic and hypotensive on arrival. Of course, you give him antibiotics and IV fluids immediately, but an hour later, the lactate comes back at 5, and the nurse calls you got to give norepinephrine to keep that MAP above 65. You call up to the ICU to get him transferred, and the intensivist asks you whether you have started the personalized hemodynamic resuscitation targeting capillary refill time. Now, of course, you don't want to sound dumb, but what the heck is personalized hemodynamic resuscitation protocol targeting capillary refill time?
Hey, full disclosure, I have no idea what they were talking about. So sepsis, though, I do know that sepsis is a life-threatening organ dysfunction caused by dysregulation of the host's response to an infection. And septic shock is the most severe end of that spectrum. Patients with sepsis have persistent low blood pressure, requiring vasopressors to keep that MAP above 65 millimeters of mercury and a lactate greater than 2 millimoles per liter, despite adequate volume resuscitation. And when you look at high-income countries, mortality has fallen. So we've made some gains there, but the mortality still remains substantial. And in many settings, mortality can be between 30 to 70%. High-quality ED care requires early recognition. Hey, I think that's sepsis. Let's get the antibiotics going. Source control, hemodynamically directed fluids, and plus or minus some vasopressors.
Now, the management of septic shock has changed dramatically since that long ago time when both Ken and I started practice. We went through a period where we were very aggressive. We used that bundle of care that was suggested by Dr. Emmanuel Rivers, published back in 2001. But then we ran the big trials looking at the components of that bundle, and we found that none of them seemed to help individually. Those were the ARISE, the PROCESS, the PROMISE trials that you'll remember. And it was really clear that these patients benefited from close attention and clinical reassessment. But aside from that, the early antibiotics, the exact interventions that were needed remained unclear.
Yeah, Dr. Rivers deserves some credit for really focusing our attention on sepsis and making us more aware of it and recognizing it early. But the specific interventions and some of the things in the bundles didn't pan out as promised. And for a while, many people focused on trending lactate levels. Ooh, that was the rage. Oh, what's the lactate? What's the lactate? When we saw the original Andromeda shock study, which showed that a resuscitation strategy focused on clinical assessment of the cap refill time was at least as good as a strategy focusing on trending those lactates.
And I was a big fan of the Andromeda shock trial initially, and I changed my practice. I started looking at those cap refills, but we were left with this big question. How exactly are we supposed to improve that cap refill? And what other targets might be important? There's been a question about whether maybe a higher MAP target might be important, especially in elderly patients with higher baseline hypertension rates. But then there's the recent Optra study that actually showed worse outcomes when we targeted a higher MAP in elderly septic shock patients.
Humans are complicated, aren't
Yeah.
they? So therefore, aside from that consensus that, hey, providing early antibiotics, we all kind of agree, we think you've got sepsis. We probably should give antibiotics as soon as we think that is a good idea. There remains many questions about the ideal resuscitation strategy for septic shock patients. All right, Justin, what's the clinical question?
So in adult patients with septic shock, can a composite of death, duration of vital support, and or hospital length of stay be improved by a, quote, personalized hemodynamic resuscitation protocol targeting the capillary refill time, end quote?
Yeah, exactly what the intensivist asked you. Okay, how about the reference?
So this is Hernandez et al. It's the personalized hemodynamic resuscitation targeting capillary refill in early septic shock. It's just the Andromeda Shock 2 trial, JAMA 2025.
And let's go through the PCOT. What was the population?
So these are adult patients with septic shock using the Sepsis 3 definition. They had to be on vasopressors after at least 1 liter of IV fluids, and they had to have a lactate over 2, and they had to be enrolled within 4 hours of this shock onset.
And like many studies, they had multiple exclusions. I'll list those in the show notes. How about the intervention itself?
Yeah, it's really hard to describe in podcast format, but it's a 6-hour stepwise algorithm that they call this personalized hemodynamic resuscitation targeting capillary refill.
Yeah, let's not go through the fine details of that based on some of our interpretation of the study. So what did they compare this to?
Just the usual care based on local protocols or guidelines.
And their outcomes, what was their primary outcome of interest?
So it's a composite outcome. It's actually a hierarchical composite outcome with a stratified win ratio. The components of the outcome were, number 1, a 28-day all-cause mortality. Number 2, duration of vital support. And so that's time on cardiovascular, respiratory, or kidney support, again, through 28 days. And then number 3 is hospital length of stay through the 28-day time period.
And this is the woot, woot, woot nerd alert. We're talking about hierarchical composite outcomes. I hope Scotty Weingart, you listening? We're going to be talking about that. All right. And what about the secondary outcomes?
The major secondary outcomes is just each of those components individually.
And what type of trial was this?
This is a pragmatic, multi-center, open-label randomized control trial.
So the author's conclusions were, quote, among patients with early septic shock, a personalized hemodynamic resuscitation protocol targeting capillary refill time was superior to usual care for their primary composite outcome, primarily due to lower duration of vital support. All right, let's quickly breeze through this checklist for randomized control trials. So this study population, is it just looking at people in the ED?
So no, although some patients were enrolled from the ED, this is an ICU-based trial.
All right, and the patients, were they adequately randomized?
Yes, they used good methods, web-based randomization. They used 1-to-1. They did it in blocks, and they stratified it by sites.
And did they conceal this randomization process?
Yes, they did.
And were they doing an intention to treat analysis?
Yes, or almost, or technically. I mean, it was a modified intent to treat analysis. They analyzed the people who met eligibility, were randomized, and consented, which is a few less than the total randomized.
And the patients, were they recruited consecutively?
Yes, or at least we think so. They say that they recruited consecutive patients, but they don't have that standard flow diagram or any information about how patients were screened, so it's a little bit hard to follow the process.
And the patients in both groups, were they similar with respect to prognostic factors?
Yes.
And all participants, were they masked to their group allocation?
No, and of course, this is a big one. This is an unmasked or open label trial.
And were all groups treated equally then, except for this intervention?
I think we have to give this an unsure because this is an unmasked trial and the intervention group has to spend more time at the bedside than just your usual care. I think it's reasonable to think that there might have been differences between the care that's not covered just by the components of the protocol. And the other aspects of care received are just not well enough described in the manuscript for us to be sure.
And how about their follow-up? Was it complete?
Yes, we believe so.
And do you think that they included all patient important outcomes?
I'll give this one an unsure. So mortality is identical in this trial, and we're going to talk a little bit more about whether we think this vital support-free days is a truly patient-important outcome. But aren't measurements of like longer-term functional outcomes, longer-term renal outcomes, which I bet you patients would consider more important than some of the components of their composite. And there's also very little mention of adverse events.
And the treatment effect, was it large enough and precise enough to be clinically significant?
Another answer of unsure, and we'll have to discuss it a little bit more below, but the use of the composite outcome that combines both important and less important outcomes, as well as the use of the stratified win ratio, makes it really hard to describe the difference between the groups, and it makes it really hard to describe the true treatment effect, if any. Given that there was no change in mortality, my sense of the answer to this question probably should just be no.
All right. And the final question, where'd the money come from? Any financial conflicts of interest, those types of things?
I actually found the funding of the study quite interesting. Essentially, the researchers at each study site had to find their own funds. So this is like truly researcher driven. Although these researchers do have a few ties to the industry that they list out, there doesn't seem to be any obvious financial conflicts of interest relevant to this specific protocol.
All right, let's dive into the results. You mentioned earlier they randomized about 1,500 patients and were able to analyze almost all of them. The median age was about 66 years and 43% were female. When you looked at the severity, how sick were these patients? They had an Apache score 2 of about 18 and a SOFA score of 8. And what type of infections were these? Well, half of them were abdominal, 20% respiratory, 20% urinary. And for baseline support of invasive ventilation, about half. And to get into this, to be included, you had to be on vasopressor support. So no surprise, 100% received vasopressors. And in this case, it was norepi. And the lactate median was 3.6. When they looked at the median time from shock criteria to randomization, it was 2 hours. All right, with all that said, what was the key result?
So compared to usual care, this capillary refill guided personalized resuscitation produced a statistically significant advantage over usual care in their hierarchical composite, which seems to be mainly driven by a shorter duration of vital support, while 28-day mortality was nearly identical between the two groups.
Yeah, you got to get into the details here. So let's talk about that primary outcome.
Based on their stratified win ratio analysis of their composite outcome, there were 131,131 wins for the personalized resuscitation group and 112,787 wins for the usual care group. Those are big numbers, Ken. The resulting win ratio is 1.16, which is statistically significant with a p-value right on the edge, p0.04.
Yeah, when you looked at that 95% confidence interval to see if it crossed the line of no statistical difference of 1.0, it was 1.01. All right. And then, they had a bunch of secondary outcomes. And with any composite outcome, really the devil is in the details. And we mentioned this earlier, no statistical difference in mortality. It was about a quarter in both groups.
And then the change in this trial comes down to vital support-free days. It was 16.5 versus 15.4. Now, this is one of the reasons I approached you. This is actually a composite within a composite, which is a little bit confusing. What exactly are vital support-free days? And unfortunately, in the manuscript, they don't really report on the specific components of this. But if you dig into that supplementary material, which is always fun to do, there does not seem to be any difference in the use of mechanical ventilation or vasopressors. So I think the difference in this trial might come down to about a 1-day difference in renal replacement therapy.
And there was also no statistical difference in hospital length of stay. Everybody was in for just over 2 weeks. All right, now's the fun part. Glad to have you back, Justin. I love talking nerdy with you. So you ready to go?
Absolutely. But because you really love that number 5, I think I got to sneak 1 point in before we get to the formal 5 issues.
What? Okay. All right, you go ahead.
All right. So obviously, the way we've been talking, I'm not overly enthusiastic about these results, but I think there's a bias to consider that would tell us that this trial could actually be underselling the importance of personalized resuscitation. And that's the idea of contamination. This group of researchers is incredible in a lot of ways. They're very enthusiastic, and they did a lot of teaching before this trial started. They managed to pull off an incredibly complicated study without external funding, and so obviously they really believed in what they were doing. Now, as a result of the education and enthusiasm, it is quite possible that the physicians trained in these techniques might start using them even when their patient was randomized to usual care. And the closer this capillary refill protocol is to usual care, the less opportunity there will be for us to see a benefit. So I would be a little bit worried about being overly nihilistic in our interpretations of this trial, right? I already regularly perform assessments of capillary refill in my septic shock patients. I'm already doing some of the things they describe here. So rejection of this specific 6-hour protocol does not give us permission just to completely ignore the septic shock patient.
Exactly. We shouldn't be ignoring the septic shock patient, but it might be that all this training and enthusiasm was just putting more time, effort, and attention to this important thing. If we throw resources at a condition, whether it be code MI, code stroke, code sepsis, all of these things get better. But is it due to the individual thing, like, putting your finger on a slide and watching the time and looking for a cap refill? Was that the thing that did it? Or was it that you were just spending more time with the patient and being more attentive to that patient? And certainly the nerdy section is not to be harsh about any study. We recognize how difficult it is to design, implement, complete, and get a study published. We're not living in glass houses throwing rocks here, people. The nerdy section is to help us figure out the limitations and think about methodologic compromises, and also learn new methodologic techniques, which we weren't aware of, and consider how should we clinically apply this data. And again, the SGEM bottom line isn't, we can just ignore shock patients. That is not the message that I want you to get from this episode. But let's get to the 5 points. The first one is the unmasked trial with subjective outcome changes. In open label trials like this one, it increases the risk of performance bias and mortality, while an objective outcome and completely unchanged here, the component outcome that really seemed to change this overall composite outcome was vital support-free days. And the treatment decisions about vital support-free days is subjective and can be influenced by treatments the patients already received. Therefore, this outcome is at high risk of bias in this unmasked trial design.
Nerdy point number 2 we could probably talk about for an hour is composite outcomes in general. Composite outcomes have been discussed before on the SGEM multiple times. They are endpoints in clinical research that combine multiple individual events. In this trial, they combined all-cause mortality, vital support, and length of stay into a single measure to capture the overall effect of this intervention.
And composite outcomes can be useful when the individual events are too rare to provide adequate statistical power, allowing researchers to direct treatment effects with smaller sample sizes or choosing shorter follow-up periods. However, composite outcomes come with a trade-off and must be interpreted cautiously because the components may vary greatly in clinical importance or frequency. In addition, the trial's reported benefit may be driven largely by a less important or more common component rather than the outcome that patients really care about, the poo.
Whenever I find myself reading a trial with composite outcomes, I find myself spending way more time focusing on the secondary outcomes, which to me is a bit of a red flag. In this Andromeda Shock 2 trial, there was no 28-day mortality benefit, but there was a statistical difference in fewer days on vital support. Performing their hierarchical composite outcome gave them a win ratio of 1.16, and that does mean there's a net advantage here for this capillary refill guided personalized resuscitation strategy.
All right, the third one, and this one's really for Scott Weingart. This is lipstick on a pig. And I'm certainly not making any comment about Scott. He's a handsome man. No, one of the criticisms of composite outcomes is that each outcome is valued the same. And changing the analysis into this hierarchical model with pre-specified outcomes of importance attempts to address that limitation. Let's put death first, and then major morbidity second, and then resource utilization.
So the way this technique works is it typically compares each patient in the intervention arm with each patient in the control arm. So these are matched pairs, and they determine whether it's a win, a loss, or a tie first based on the highest priority endpoint. So they would look at mortality first. Only if they tie at that highest level do they then proceed to check them on the next level down.
Yeah, and the net effect is you get this summarized win ratio or stratified win ratio, if stratified by baseline risk. And the number of wins of the intervention divided by the number of wins of the control, so values greater than 1, would favor the control. And there's some foundational methods that include the Finkelstein-Schoenfeld global rank win-loss test, the Pocock win ratio framework, the Buzzy generalized pairwise comparison, and the Win-Locken family of multivariant rank tests. Now that everybody has had a little chance to nap, you can wake up and listen to the rest of this, because I'll put a table in the show notes that provides a pro-con list of these hierarchical composite outcomes with a brief explanation for each one.
And the whole idea of ranking your composite rather than just combining them all together certainly makes some sense. The first time I read one of these studies, I was sort of excited about the idea. But on reflection, I'm less sure. I think the big question might be whether this methodology really helps us as clinicians understand what is going on here. One major problem with a hierarchy is that the primary outcome is still just presented as a single number. It's still discussed as a single outcome. That's how it's discussed in their conclusion and in their abstract. So that hierarchy really isn't actually represented in the way the outcomes are presented. Instead of discussing the outcomes separately, they still get lumped together, making it somewhat confusing. Again, I read this paper multiple times, and it's hard to really tell what's going on with the patients here, what actually changed.
And the hierarchical methodology is not such a big problem if it's done well, right? Because there are limitations to every study design. And it's a reasonable approach to improve the standard composite outcome. But even though you're doing hierarchical outcomes, you should still be registering them up front to avoid harking, and that's hypothesizing after the results are known. And the results for each component should be reported side by side, just to avoid some selective emphasis.
Yeah, like in all methodological and statistical methods, we wouldn't use the word spin ever. The results are the results, and how we interpret and communicate the clinical meaning is what is important. Personally, when I read a trial like this, I start with the patient-important outcomes. I'm looking for mortality, functional status, major morbidity, and I'm left with a question of whether that combining them together truly helped, because I spend all my time just looking at those secondary outcomes. I think the big key is that we can't hide outcomes within a composite. Is going to be our biggest task.
Yeah, you don't want to obscure it with putting it together in a composite, because you're basically burying some information then. And it's important to be transparent about what drove the win. And in Andromeda Shock 2, the hierarchical primary outcome favored that personalized resuscitation strategy with a win ratio of 1.16. But it was largely driven by fewer days of vital support, while that mortality wasn't changed. And this information should be presented plainly so clinicians and patients can judge whether the trade-off is worthwhile in their context. And the authors do include the different components of their outcome, although it's a secondary outcome.
All right, Ken, that might have been enough even for you, enough stats talk. So maybe we should turn on to point number 4, get back to some clinical points. This is about the bundles of care. Studies that look at bundles of care are just always harder to interpret because, which parts of the bundle mattered? Were they all equal? When they're lumped together, it's actually possible that some parts of this bundle could actually be hurting patients, and the harms are just outweighed by other parts of the overall bundle. This is especially important when the bundle is very intensive and will be difficult to replicate in many clinical environments.
Yeah, and we've done this before with sepsis. We had the surviving sepsis bundle by Dr. Rivers, and over time we found out that the components of the bundle weren't really improving the patient outcome. It seemed just like extra attention was the key as long as we did some of the basic stuff, and I hope we can learn from history.
And the question might be especially important because in the time that this trial was being run, we just had the publication of the Optris trial, and it showed actual harm from higher MAP targets in elderly patients with septic shock. The protocols and the patients are not the same between the two trials, but I think it is a reminder that a bundle could include components that actually cause harm.
All right, so you brought it back to the patient. Now I'm going to put on my MBA hat and talk about, flow and opportunity costs and things like that. And this intervention, as described in the manuscript, at least it would take me a lot of clinical time to do it. And obviously, if that time is worth it, if we're saving lives and if we're saving lives with good function, I'm all in. However, we must remember that the time that we spent, every minute that we spent at this patient's bedside is a minute taken away from other undifferentiated patients in our emergency department who are waiting for our services.
And this is something we do over and over again in emergency medicine. We get really focused on one problem and forget about all the patients in our departments, right? We will throw tons of resources at one thing, whether it's your code stroke, your code sepsis, your code MI, your code paronychia, and you'll show a performance for that one thing. But what about all the patients sitting in the waiting room? And so considering the fact that mortality is completely unchanged, I think you really have to sit back and think carefully, is this worth it?
So Justin, you don't see one patient a shift? That's not your flow? You've got more than one?
I haven't moved to a downtown academic hospital yet.
Burn. Oh, I sense that I'm going to get some emails over that comment. Okay, let's comment on the author's conclusions, comparing them to the SGEM's conclusions.
So we would just slightly quibble over the language. They conclude that this personalized resuscitation protocol was superior to usual care based on their composite outcome, using the word primarily due to lower duration of vital support. That is technically true, but it, to me, primarily seems to imply that there were other benefits as well, and I'm not sure there were.
Yeah, we would conclude that the trial found no changes in mortality and put that in the actual conclusion. But this resuscitation protocol might decrease total days of vital support, primarily in the form of renal replacement therapy. All right, you got to give us an SGEM bottom line then.
Yeah, I love this trial. This is interesting research. It warrants follow-up, but considering its open-label design and the lack of mortality change, we do not believe that this protocol is ready for routine practice.
And how about the case resolution where you're talking to the intensivist?
Thankfully, like the amazing emergency doctor you are, you always keep a very close eye on your critically ill patients, as you're able to tell the intensivist that the patient's capillary refill has actually been improving since the fluid bolus, but it's not yet normal. So she asks you to start one more fluid bolus, and then she'll reassess the patient as soon as they arrive in the ICU.
And then how are you going to take the Andromeda Shock 2 trial and apply it clinically?
So this paper reminds us that septic shock patients still have a high mortality, and they may require individualized plans to deal with that shock. The evidence is probably not strong enough to recommend this specific protocol, but it is a good reminder that the answer to low blood pressure is not just reflexive IV fluids. A more holistic approach is required to the patient, including clinical assessment of tissue perfusion and at times adjuncts like echocardiography. All of those might guide your resuscitation.
And do you have an opportunity with this type of situation to tell the patient anything?
Yeah, unfortunately, most critically ill septic shock patients are not awake enough to have this conversation, but I'll tell their family that they have a life-threatening infection and that researchers around the world are thankfully doing their best to find ways to improve outcomes. But for now, I'm just going to keep a very close eye on them and adjust their treatment as needed.
All right, it's time to announce the Keener contest winner, and last week's winner was Olof Laren Sangren, an attending physician in Sweden. He knew Batman's one rule is he doesn't kill. What's the question this week, Justin?
Yeah, this is people have to know their classical mythology. Who was Andromeda in Greek mythology?
Yeah, you got to know your classics, don't you, if you want to be an uber nerd. So if you know who was Andromeda in Greek mythology, then all you have to do is fire off an email to me with thesgem@gmail.com with Keener in the subject line, and I will give you a big shout out on the next episode. There are some other FOAMed resources on this, the one from Scott Weingart on MCRIT, and of course, your blog post on First 10 EM. Thanks, Justin, for flagging this and coming on the show to go through it and talk nerdy with me.
It's a pleasure, as always, to be here.
And could you read the SGEM tagline?
Of course. Remember to be skeptical of anything you hear, even if you hear it on the Skeptic's Guide to Emergency Medicine.
Talk to everyone next week.